All right, the man, the myth, the legend. Dr. Howard Ralph is sort of like Santa, the Easter Bunny, and the Tooth Fairy all wrapped in one. And I hope he doesn't get offended by me saying that. No, Dr. Ralph is a veterinary surgeon, anaesthetist, and doctor of medicine with qualifications in wildlife medicine and clinical forensics. He also holds qualifications in education and the fine arts. For over 40 years, Dr. Ralph has practiced medicine in humans and animals. He has received numerous awards for his work with wildlife, including New South Wales Senior Volunteer Award in 2013 and Sydney University Veterinary Science School Alumni Award in 2017. He is also featured in many publications and media, including the cover story for the March 2017 issue of Vet Practice magazine and ABC's Australia story in October 2017. In January 2019, Dr. Ralph received the Order of Australia Medal for his work on Australian wildlife. Dr. Ralph teaches various aspects of wildlife treatment and care in a variety of species around Australia. He has also given training on animal treatment and care overseas in Indonesia and Nepal. Dr. Ralph has attended, in his capacity as a veterinary surgeon, several disasters such as oil spills, floods, cyclones, and bushfires, and assists in the treatment of animals for Tree of Compassion in Nepal. Together with his wife Glenda, he established Southern Cross Wildlife Care, which includes a purpose-built wildlife hospital in the New South Wales Southern Tablelands, providing treatment for wildlife all over the region and beyond. Dr. Ralph treats hundreds of patients every year, from kangaroos, wombats, koalas, echidnas, birds, to snakes, turtles, and frogs. Please give a warm welcome to Dr. Howard Ralph.
Just that one there, yeah.
That one's the next slide, which is
No, just that.
okay. So that's next, right? Okay. Good afternoon. Thank you very much for this opportunity to talk about diarrhoea just before lunch. That's me for those I've never met. I've met most people here, I guess. So I've been around a while and I've been involved in many different types of activity in human medicine, veterinary medicine, wildlife, forensics and so on. And if I ever get 5 minutes, fine arts, but that's low on the list currently, sadly. Nevertheless, we battle on, and consequently, because of my involvement in many of these aspects of the world, I've actually been in close contact with a huge amount of diarrhoea. So I think that I've got a bit to offer about the management thereof, so we'll do our best. Our wildlife hospital in the Southern Tablelands and referral service, we treat any species for any problem, and we do a lot of motor vehicle accident trauma, which is orthopedics, and spinal surgery. We do cataracts and other soft tissue surgery, but we also see a lot of little fellas, and one of the common presentations to our hospital is diarrhoea. So we're very familiar with it, and the point about it is it's a really important matter, because if it's not attended in a timely manner, it's a fatal disease. So we're going to talk about some of the things, what to do about that, and how we can avoid those bad outcomes. The problem with all of this is that the bowel is the main contender, and the bowel is complex. So we'll talk a little bit about that. But when it comes to diarrhoea, the definition basically is that it's a lot of stool, frequently, very loose, and there's an element of loss of control. Now, when I go, your notes will show a lot of other things that we'll not have time to talk about in detail further on, and I apologise for that, but I thought it better to include them rather than leave them out, because it is very complicated, and I'd like to make sure that we cover the full spectrum. So when it comes to diarrhoea, we look at it in various ways, and one of the important things to do is to assess the patient and the diarrhoea, both macroscopically and microscopically. This is a fairly straightforward, common experience for some, and this is pretty standard, sort of simple diarrhoea. Unfortunately, when things progress, we end up with a lot of bleeding in the bowel, and this is given the title of dysentery. And when we see this, we start to think, well, there's a major deleterious event brewing. The next type we see is black stool. This is partly formed, but when we start to see black stool, if we haven't given charcoal treatment, the problem is that there's bleeding in the bowel further up, and we're in for really big trouble. And this is called melena. And it's a very big danger sign. We need to look for why this is happening and deal with it very quickly, because things are going wrong. The next thing we get is what's called spurious diarrhea, which is when the bowel is partly blocked, particularly down in the lower reaches near the pelvis and just beyond, and all that's getting past is a little bit of liquid. And the problem mainly is not the fact that there's severe diarrhea, but there's severe constipation, and that the only thing that's getting through is the liquid. And then, of course, there's explosive diarrhea, which comes as a bit of a surprise to us and the patient. And that's a bit of an exciting time, depending on the species. So when we're talking today, I'm talking about general diarrhea in all species. The title was Diarrhea in Kangaroos, but the same principles apply to all species. So keep that in mind. If we've got a 60-kilo kangaroo with explosive diarrhea, you need to hasten quickly and do something about it. The gastrointestinal tract is complex, and I've included in your notes a summary of the main components thereof. So it starts at the mouth and ends at the cloaca or the anus, and includes all the things in between, like the esophagus, stomach, duodenum, jejunum, small intestine, that is, large intestine, cloaca, and the cecum. And all of those things are involved in this process of either causing diarrhea or assessing it or doing something about it. There are a lot of associated organs, including the pancreas, which is critically important because whatever happens in the bowel can either be partly caused by these other organs or it has an influence and reflects upon their welfare. So the bowel is not an isolated tube, it's associated with all these other organs, which are listed in your notes, and I won't go through them. Time is limited, so we haven't got 8 hours, we've only got 6. So we'll just take it as read that some of these things we've talked about. The liver and gallbladder are obviously important, and they produce bile, which is important for digestion. The adrenal gland offers a number of enzymes which are listed, and the pituitary gland. The two are linked together, but they all reflect on the bowel. The central nervous system has a control over what happens with the bowel and what the patient does about it, particularly at the bottom end. Things like the bone and skeleton, the thyroid gland, the parathyroid gland, and skin are all associated with activity in the bowel or absorption of nutrients or something that can either cause trouble or result in trouble because of the diarrhea. People talk about the GIT as the abbreviation for the gastrointestinal system. Here's a photograph or a diagram more or less of the components of the bowel. I'm sure you're all familiar with that, we won't dwell on it. And a list of all the other organs associated with the bowel and therefore associated with normal function or diarrhea. So what about causes? Well, once again, it's complex, and there are many, many different causes of potentially causes of diarrhea which we need to recognise. The first one and the main one, which is the overall end result of a problem, is that the bowel is disturbed and the ecology of the fecal matter in the bowel and the bowel itself is upset. So what we need to do is focus on why that happened and what can we do about that. And a couple of other speakers have talked about or suggested things about that already, and it's the thing that we come back to all the time, that the bowel is upset by many of these disturbances, but the final outcome, the final common pathway, is a disturbed ecology. Excuse me, so we need to aim back to that. A very common cause, and this is a typical bowel, believe it or not, this wombat actually presented with abdominal pain and diarrhea with very little history, But this is a really badly disturbed bowel. You can see the bowel is actually ruptured all the way along there. I've got it there. This is the large intestine. This is all the blood vessels, and the bowel is ruptured along this margin, which we found at laparotomy, which we'll talk about later, which is opening the abdominal cavity to find why there are certain clinical signs going on. This is just another example of it, but the main focus is this material, which is sometimes normal bowel content, depends where it is. But when you get down to the lower reaches of the bowel, you expect that will be hardening up and not quite as liquid and fluid as that. Unfortunately, this poor fellow didn't survive because he had severe peritonitis from this massive rupture, which is the end result of stress and a bowel disturbance, which led to a rupture of the bowel and his demise. So stress is a big deal, and we talk about it in human medicine. We talk about irritable bowel disease and a whole lot of other concomitants of that, which can be simple things like a fractured leg, for example, can lead to diarrhoea. And in the species that we're particularly interested in, many other things that are wrong can lead to diarrhoea because of the stress. So a diet upset and so on, all can lead, because of the stress being the common denominator, we end up with diarrhoea and, in humans, irritable bowel syndrome. Obviously not a kangaroo, but I included a few other species just to break things up a little bit, and because he's very cute, even though he's got an attitude. But it demonstrates the sort of stress behaviour that we see all the time. And this little fellow is a candidate for getting diarrhoea because he's in a situation, his problem is mostly not his bowel initially. His problem is, in fact, that he had a tail that was degloved and we had to deal with that. But an end result of all of that is that he's severely stressed and we get diarrhoea, so we've now got two problems. This little fellow, this little Joey, is showing the typical signs of stress that we see in macropods, particularly in the young. He's got this alopecia, diffuse alopecia, partly on the ears, but along the body here, and you can tell by the look on his face, and that's what we look at. Even though you can't see the Joey, by the time he puts his head out of the bag, bag that he's in, you can tell straight away that he's, quite significantly stressed. Therefore, we may be heading for trouble. Here's another example. In the very young, we see this quite commonly. This is a seborrheic dermatitis, and when the skin is flaking off, it's a stress phenomenon. We see it in all species, and we see it in all ages, but particularly we see it in young Joeys who are under stress, and they end up with this severe seborrhea, which in fact itself can be life-threatening. So it's a significant finding, and we can treat it. We get to it early, we can treat it. Here's another stress phenomenon in a macropod. The feet is losing all this skin along the base of the feet. That's obviously been going on for a little while. It didn't happen yesterday, but it's another stress phenomenon, and you would expect that this little one would be a candidate for diarrhoea simply because we've got all this stress going on. Here's another one. This is a really important one because little Joeys, they end up with these circumferential rings of tight tissue around the tail. And if it's not dealt with, they act as a tourniquet anywhere along there, and they end up with a dead tail. So it's a really important problem, and it's not difficult to treat in the early stages, but we have to get to it early. Here's another one, obviously not another kangaroo, but under stress, and we need to recognise these signs. Obviously you all do, but I'm including them for completeness. But he's obviously stressed and he says, I want out. Thanks very much. Now, it's a matter of who's stressed here. I have to say that this patient was very dignified, and so I escaped this event anyway. But stress is in all species, we look at it as one of the primary problems that we're facing all the time. What's the next issue? Another common problem that we find as a cause of diarrhoea is dietary indiscretion, and that can be to do with any number of things that we inflict on the bowel, like it was mentioned earlier. Overload of the bowel with solute, that is solid matter, when the bowel is not ready for it. Particularly when the bowel is a little bit troubled, if we overload the bowel with extra solute, then you end up with osmotic diarrhoea. And this can happen even with a normal bowel if you push it too hard. So we need to stick to the rules when it comes to what percentage of solute and liquid we actually introduce into the bowel. A sudden change of diet, even though it might be normal food, a sudden change of diet may precipitate diarrhoea, particularly if the second food is rich. Might be the wrong type of food. So we need to know whether the patient is a carnivore or herbivore or whatever. So giving them the wrong type of food, because the bowel is not capable of digesting that food. So we need to be careful with that. Parasites of various kinds. Here's a couple of things that we need to just take note of. Here's some milk powder, condensed milk, and even skim milk can get into trouble because of the fact that we're treating it should be a lactose-free or very low lactose diet. These things are much more suitable. Even soy milk, in a difficult situation, we find that soy milk is quite good and they like it, so they'll drink it. Even though they might feel a bit off colour, they're quite happy to drink soy milk. Parasites, well, now we open the books. There are many of them and they come in all guises and all species have them, and people say, well, it's normal to have a few, which is true, but that's generally in the wild. We're generally talking here about species or patients that are not in the wild, have been brought into care, they're already under stress, and so parasites get free rein to increase in number, and sometimes to very large numbers. And once again, it's to do with the upset of the ecology of the bowel. So we need to take account of the fact that we've got all these different sorts of parasites. For example, worms, of many kinds of worms, they all have their place, but some are more difficult than others to treat. So we've got worms like this hookworm type creature and simple worms, strongyloides or strongyle worms. Here's some strongyloides, and it's an action shot. Here they are being born and ready to cause trouble. Here's one that we've got under the microscope. All sorts of other helminths, for example. And then we come on to other different types of worms like these liver fluke, which can affect some of our species. And if they've got a big load of these, they'll get into trouble. Tapeworms, not very often a major problem, but nevertheless, we need to recognise them, and they tend to, in people anyway, they tend to crawl out at the wrong time, like during dinner. And so they're really not very social, these worms. Protozoa come in many types. We get all sorts of protozoa. Coccidia is probably the worst one, but there are a few others that we see from time to time. And if you look at the life cycle, this is a quick overview of the life cycle. And what happens is that the really important thing is that they get infected, they invade the bowel, and then it's like pyramid selling. They get in there, they multiply, and then they work their way out again, causing a little bit of bleeding. And then you've got 100 instead of 1, and they go back in and they keep doing this and winding it up until at the end of this, you've got 1 million exiting the bowel in one go, or the lining of the bowel, and that causes torrential and fatal bleeding. So coccidia, particularly in eastern grey kangaroos, is a harbinger of doom, and we take it very seriously. And if we've got a patient who's sick and it's got diarrhoea and there are a few or even no coccidia, but we know they're there, we treat it intensively, because we know that trying to get them through that is quite difficult. And that's why, because they build up their numbers very quickly, and you may not realise what's going on until the penultimate moment where suddenly they go completely flat and pass a whole lot of blood, torrential bleeding, and they die in a few hours. It's a major problem. Other protozoa, trichomonads, for example, we see these all the time. Now, bacteria, lots of different types of bacteria, millions of them live in the bowel, and that's normal. But under conditions of stress or something else that's upset the bowel, then any one of those groups of bacteria in the bowel can suddenly take off and become problematic because they build up numbers and then they become severely pathogenic. So that any of the bacteria, there are some that are much worse than others, which we'll talk about later. Everything's later. Fungi are common, and we see that almost universally in juvenile macropods that have got stress in particular, and they can cause diarrhoea. It's normal for them to be in the bowel, but it's not normal for them to be there in huge numbers. So it's a matter of degree, and it's a matter of picking it up early and avoiding the problem that's caused it. So this is a photomicrograph of fungal hyphae in the bowel. Viruses, there are certain viruses that invade the bowel in all species, and they can be primary or secondary, and they interfere with the normal lining of the bowel, and so the list goes on. Toxins are available, they're around about, and they come in many different types, including petroleum products and toxic plants and so on. And we find that this poor fellow couldn't find anywhere to go. He's obviously not well, so he wouldn't be hiding in the rubbish. He'd be going down his burrow. But the fact is that when there's rubbish around like this, it can contain any number of toxins, which then can be accessed by the wildlife, whatever species they are. Medications, the injudicious use of antibiotics, for example, is a significant problem. Sometimes we have to use them, often we have to use them, but we need to do it in a way that won't either initially cause diarrhoea, and we know certain antibiotics are much worse than others, but they will cause diarrhoea in their own right, or they will exacerbate the diarrhoea if they're given particularly orally in herbivores, and particularly in larger doses, and particularly in the older. So we tend to not give them orally, except under certain conditions where we need oral medication because of the bacteria that we're treating in the bowel. Such as these. These are a whole group of antibiotics that everyone would be familiar with probably. I won't go through them all, but most of these are used. Clindamycin is one that is a candidate for trouble, particularly given orally, and it's a good antibiotic for the treatment of certain protozoa. But the problem is that in oral use in herbivores, it causes a relentless diarrhoea, which is very hard to control. And they get a terrible syndrome called pseudomembranous colitis, which is fatal. So we certainly don't give oral clindamycin. The end result of some of this, of course, the other things that can happen, we can have tumours, rarely, but they do occur. Peptic ulceration, and this is something that follows stress, and we can follow the time course of this quite often. And there are certain things that happen to the patient that we can recognise as being a problem in terms of maybe there's peptic ulceration going on. One of those I've mentioned, which is black stool called melena, but there are others. And examination by the veterinarian is really a very good way to pick this up, even though marsupials tend to hide their feelings a little bit, except if you're trying to do something with them. But they do tend to become difficult when it comes to examination. And even though they might have peritonitis going on in the abdominal cavity, young juvenile macropods are very difficult to examine because they don't behave like dogs or sheep or people. And they tend to hide the pain, and picking up a severe abdominal problem is quite difficult. But one of the things that we're looking for all the time is peptic ulceration. And here's an example of a stress phenomenon. Here's the duodenum, and at laparotomy operation, here's a rupture in the bowel. And this is caused by peptic ulcer from excess acid and stress and so on, causing this bowel to rupture. And now we've got a major problem because of peritonitis, and that is quite reasonable in terms of repairing it surgically. So in that sense, it's not a major issue, except if it's been going on for a while and they've got pus all over the place, like the one we saw at the outset. And then it's impossible sometimes. Spurious diarrhoea, well, I mentioned that already, where you've got an abdomen full of fecal matter and it's not moving through into the bowel, and so the only thing that's getting past is a little bit of fluid, and that is misinterpreted as diarrhoea. And if someone's examined the patient and found that they've got a blockage rather than simple diarrhoea, and you give them things to slow the bowel, of course the blockage gets worse, and then you end up having to do an operation to fix it. In this case, we know why we've got this problem in the bowel, because those who are looking carefully will see there's a fracture in the spine caused by the usual thing, motor vehicle trauma, which we see all the time, and it really is a major impost on our wildlife. So this is spurious diarrhoea. A couple of other things mentioned. I won't go through the lot because you can read that at your leisure if you have any. I say that advisedly. Okay, diagnosis. Well, what are we going to do about all this? We know that there's a potential for diarrhoea. We've seen the result of that with one of these things coming out of the bowel, whether it be runny or explosive or whatever. And so we need to try and make a diagnosis. And the critical issue is we need to do that early, because if you've got a diagnosis, you can have a better treatment. So an early diagnosis is critical in the scheme of things. And one thing that you provide to the veterinarian is the detailed history. One way that we do that, a lot of carers come with the Joey that's been in care a few weeks and now they've got diarrhoea, and they've got a very detailed summary of their clinical history, which is fantastic because it gives the veterinarian a really good insight into what's been going on, and it can lead the way. And the history is often gives the diagnosis, potentially. Does that mean I'm finished? No. All right, I thought not. So the history is really critical. And when did the diarrhoea begin, and what treatment has been given, and have they had a veterinary examination? Is it a recurrent diarrhoea, or is it mild, or whatever it is? So getting a detailed history is critically important. Then we need to know, what's the diarrhoea look like? This is all fun, really, isn't it? What about the diarrhoea itself? What's it look like? Well, here's a pretty standard sort of diarrhoea that you would have all seen. It's green, it's loose, it's obviously all over the place, and this gives us a clue as to the cause. So this is all forensic medicine with diarrhoea, and it's really important because we may have no other evidence at some point, but this gives us a clue as to what might be going on. And then we look for things in the diarrhoea. Was anything noticed? Were there foreign bodies? Were there worms in the diarrhoea? And it depends on the number and the type and so on as to whether this is relevant. But it's important that we know that. Obviously, it's not a kangaroo, but I'm sure I don't need to mention that, but I thought I should. And we've got these additives in the diarrhoea. This is a worm obviously coming straight out through a ruptured bowel, and we need to know that to be able to treat it properly. There are a few danger signs on the way through the history and then the examination. There are a few danger signs that we look for. They're listed there, and I'll go through a few of them because these are critical in terms of what do we now do, and are we facing a major catastrophe? And some of these will give you the clue, like dysentery. This is a major problem and it cannot be ignored. It may be that we're heading for a significant collapse of the whole system and a death. So having this sort of bright red blood appear, one needs to pull out all stops to deal with that, find out what it is. Is it coccidia? Is it a ruptured bowel? What is it? And the next thing to do is to look for, in this little Joey, you can see he's looking very miserable. That's a major problem. It means that he's succumbing to his problem with the diarrhoea, and that needs urgent attention. We can't just treat the fact that everybody would have noticed that he's got melena. So he's very likely got a ruptured bowel and a peptic ulcer, and he's going to need an operation. But he will need resuscitating beforehand because he's obviously in not a very well fit state for a major procedure. So this is something you pick up early and we deal with it. Advanced dehydration and cachexia, we've already heard that today, but this little fellow's been suffering for a while and he's getting to the point of no return. So we need to, he's looking miserable, but he's still with us and he's sort of pleading for help, which I can understand. He probably feels really rotten. So he's lost all this weight, he's very dehydrated, he's sitting there not even bothering to get up and looking poorly. Another really big danger sign. Here's another one. This is the end result of a catastrophe, of course. We've got a bowel with this is what you see with coccidia. You may not see it, the patient may die before you see this, but this is what we see at post-mortem. So this bowel is totally collapsed and the patient bled to death effectively. All right, a number of clinical signs. If we examine the patient, you and I, we examine the patient, we look for a whole lot of things like, in this case, this macropod, first thing you notice is there's excessive salivation. He feels really ill. He's not swallowing his saliva or he's producing more of it because there's an irritation somewhere here. And the other thing that you can notice is what? He's cyanotic, he's blue. So his cardiovascular system is collapsing. He's going to die if we don't do something urgently. So here it is. It's a blue tinge to these oral membranes and the excess amount of salivation. These are major signs of pending disaster. One or two others. Bubbly diarrhoea. We talked about that already. Sometimes that is simply treated, but we need to know why it's bubbly diarrhoea and often explosive when it comes to that. No bowel sounds on examination. We listen to the abdomen, either with a stethoscope we do, or if you don't have that, you can listen with your ear, not around near the bottom end because he might have explosive diarrhoea, but at the side of the patient, you can hear, sometimes you can hear the bowel sounds, and they could be excessive or they could be absent. If they're excessive, we're probably all right. We can deal with that. If there are no bowel sounds, this is a major disaster and he's in really big trouble. And if we don't do something about it, he will die. So bowel sounds are critically important, and it's one of the things that we look for, I look for, when I'm presented with a patient that's got any of these things we've already talked about. And if there are no bowel sounds, look out. Examining the general state of the patient. This little bloke's in trouble, obviously. Everyone can see that. He's starting to get seborrheic dermatitis. He's severely dehydrated. His skin is folded and dry, and he's really short of fluid. And the other thing you notice is he's ducking his head in there. He doesn't want to have anything to do with us at all. So he's really in trouble. And in the very young, one of the really important early clinical signs of pending trouble and diarrhoea and dehydration in particular is they become non-responsive and depressed and inactive and quiet. So a little quiet Joey is maybe a problem. So it can't be ignored. Here's another fellow. Look at the look on his face. He's not a happy fellow. And you can see he's standing, but look at the state of him, poor fellow. We need to help him. Here's another fellow. Examination. This is just to show that you can examine patients without taking them out and exposing them to more stress. We can examine them in the bag. We can take parts out that we need to look at, or we can often go into the bag and try to examine the abdomen or the chest cavity with the stethoscope. Sometimes I get a bit of a surprise because it's moist in there, And so then I have to go and have a wash, and then we get on with the examination. But we can do that, and it really is a very important part of examination. Taking the temperature, we've got a needle in a cannula here, but the most important part of this slide is we need to know what the temperature is. Often you can feel, when you feel in the mouth is cold and dry and they're not responsive and the circulation is poor and the capillary refill is almost stopped, and so it goes on. But taking their body temperature, we know that marsupials are a bit lower than eutherian mammals, but if you can actually document it, then you can follow the temperature as things get better, or sometimes it gets worse. A couple of other things there. I mentioned vomiting and regurgitation. That is very rare in macropods and very rare in marsupials generally, but it does occur in some. And when it does occur, it's a really important clinical sign of pending disaster, because things are not moving through at all, and they're at the state where, for a species that doesn't generally vomit, if they're regurgitating, we're looking for trouble. Having examined the patient, then and the general state, the next thing to do is move on and have a look at the faeces. And we start with the gross look of it, which is really important. And people tend to think, oh, well, it's diarrhoea. But if you look at it in detail, it's got a lot of information. And people ring us up all the time and say, oh, he's got diarrhoea. So what's it look like? Oh, well, it's sort of diarrhoea. But you can say all sorts of things about it. You know, the consistency, how much is there? Is it explosive? What colour is it? Are there additives in it? All those things are critically important for us to make a diagnosis even over the phone and say, look, you better hurry because things are going wrong. Sometimes we do culture and sensitivity. Pathologists don't like doing it very much, but because it's difficult, it's time consuming, and the end result doesn't necessarily tell you much, but it's quite important when you suspect perhaps salmonella, which is then going to be an issue with quarantine. So we look at the microscopic view of the faeces. We don't need a lot, but we can do it as a flotation, and or I usually look at a slide first off to assess what's in there in terms of how many bacteria, what type are they, is there a normal distribution of the species of bacteria, and are there any other things like parasites or fungi or additives, you know, foreign matter, undigested food. Gives you a clue things are moving through too quickly. And other things which are a bit subtle, but in this case, here's a micrograph of a patient with diarrhoea. The thing we notice particularly is there are some macrophages there, which means the bowel's infected probably, but there are all sorts of mucus cells, and they'll show up. And if there are lots of mucus cells, that gives you an immediate assessment that the bowel is irritated. So that's a very important finding. Then we move on to, I haven't got a picture of these, but coccidia come in various varieties depending on the species. But if we see any coccidia in a patient with diarrhoea that's been in care, we take it very seriously. We talked about worms, and in this case, strongyloides, which is another thing which is not given, I think, due consideration sometimes. People say, oh, well, you know, you can have a few. Well, yes, you can, but not too many. Keeping in mind also, there's a lot of evidence coming forth all the time in all species that strongyloides can cause not only diarrhoea, but they have an adverse effect on other parts of the body, causing damage, like the heart and the lung and the brain and the joints and so on. Strongyloides is implicated in a lot of that. So it's a very important critter. Trichuris, well, we see them now and again. Capillaria. If there are too many of them, then it's probably important. I think I'm getting close. Fungi, am I getting close? Okay, I'll rush. I'll speak twice as fast. I'll probably get tongue-tied. All right, we'll move on. I'll have to leave a lot of this for your reading in the middle of the night when you've got nothing else to do and there's nothing on television. We look at the urine, and the urine gives us a lot of information about If you want urine, just put your shoes out and you'll get a sample. No problem. And you can tell from that straight away it's quite clear and there's a reasonable volume. And also that your thongs are wet. So we move on. Here's an example of urine that's a bit coloured and therefore maybe more concentrated. Moving on, crystals we look for tells you a lot about hydration and so on. We do blood chemistry routinely in patients who've got significant diarrhoea because we need to look at their electrolytes and their protein, all that sort of thing. Can't go into it in detail, but we do that as a routine. In terms of diagnosis, we look at, that's not a kangaroo, but he's a friend of mine, so I had to put him in, otherwise I'll be in trouble. Anyway, he had diarrhoea too, but you can see we're feeding him with a feeding tube because he wouldn't swallow. Another one. We take x-rays sometimes and they can tell us about things. Ultrasound is an important diagnostic material. And finally, if we're really troubled and we think it's a ruptured bowel, we do a laparotomy. And at Southern Cross, we do all of this. It's a routine thing that we do. And a laparotomy, and it used to be in the olden days, Methuselah, that people would say, oh, it's wildlife, you know, you don't need sterile surgery. Well, you do, actually. And so we do all of this in the best possible way because we have great respect for our patients and their welfare. We then move on to management. If it's not requiring a laparotomy, then the management, the critical thing is that we need to talk about resuscitation because by the time the patient gets into our care, they're often severely dehydrated and going into a state of respiratory and cardiac failure. So we need to do something about, resuscitating them. And basically the worst thing that can happen is that they just dry out basically, and they're losing fluid all the time in the diarrhoea, and at the same time they're losing electrolytes and protein and other nutrients from the bowel. And so, but the worst thing, the most life-threatening thing is water. So they need water in the sense that we need to supply that in some method. Now, obviously a joey like this is not going to drink, and if you try to get them to drink, they'll just aspirate and get aspiration pneumonia and drown. So we obviously can't do that. So we need to think of some other method. So the main thing they need is water at this stage. We give the water with other nutrients as well. And now sometimes this can be given orally. If they're not too bad and they're alert and awake and drinking, then they can have this by mouth. Other methods are injectable fluid, which is initially can be given subcutaneously, which is the safest way to give parenteral fluid. If they're really sick and dry and half unconscious, there's no point trying to give them a drink. So therefore we go to parenteral fluid, and the first line of defence is to give that subcutaneously in this manner. So a lot of you are familiar with this. It's given under the skin, the fluid is warmed. It's obviously sterile. We use the smallest possible needle because we don't want to impart more stress on the patient. So we use a tiny needle depending on the size of the patient, and we give the fluid according to the amount that we've worked out. There's a table later on where we'll talk about the amount of fluid and what type of fluid. Sometimes we give it intravenously. If they're really sick, then they can't drink and they're in a desperate state, we may well give it intravenously, which means putting in a cannula and then running the fluid is at a predetermined rate. If we give it too quickly at this point, they'll drown because a lot of the fluid will end up in the lung and they die from pulmonary edema. So it's a dangerous way to go unless it's very well controlled. And of course, we use an infusion pump so that we can control absolutely the amount of fluid and the rate at which it's going in. If you didn't have an infusion pump, you'd have to be extremely careful about the rate. So giving it intravenously comes with a number of dangers, and which means that the safest way to go, if you don't have that equipment, the safest way to go is to give it subcutaneously. Other ways are things like intraperitoneal, or I've mentioned in the notes rectal. A lot of fluid is absorbed through the rectum, but I don't recommend you do that because putting tubes up the rectum, if you're not used to doing that, excuse me, can rupture the bowel, and then you end up with peritonitis and a dead patient. So the safest way is subcutaneous, but we often do it intravenously if we've got a really, really sick patient. Now, what about the fluid? Well, we need to think about a number of things. We need to think about the amount of fluid, and that depends on the degree of dehydration. So we work out, and there's a calculation in your notes, and I know that as soon as we introduce mathematics, people leave the room or hide under the table, but it's not so bad. And if you follow that through, you can work out the amount of fluid that the patient will need. And the calculation I've got here is designed for intravenous use. So basically what we do is we work on, the example is a 2 kilo joey. Let's go to a 2 kilogram joey, and we're working on a minimum of 10% maintenance fluid. So for 2 kilo joey, 10% maintenance is 200 mil. And then we work out what degree of dehydration at that stage. I've picked a number of 5%, and so we work out what's 5% of the joey's weight, which is 100 mil. We add the two together, and the amount of deficit in that joey over the next 24 hours is 300 mil. And then it's a matter of how do you give it. And as I mentioned, the calculation I've got here in the notes is for intravenous use, and it's what we use in burns resuscitation, for example. So we give 50% in the first 8 hours, but if you're giving it subcutaneously, you're going to give a lot more straight away because that'll be absorbed over a period of time. And if they're desperately sick, they can't wait. So this calculation here is for intravenous use. And if you're giving it subcutaneously, you can probably give that whole lot over a couple of hours. And then we give the rest over the next part of the 24 hours. And so they end up with the whole dose. And hopefully at that point in time, they've had their maintenance dose for the day and they've had the dose they need for resuscitation. And then they should be starting to look more lively and feeling better. Okay. Subcutaneously, different type of fluid. There are lots of different kinds of fluid, and it's really important that we pick the right one. That depends a lot on the patient. It depends a lot on how long the diarrhea has been going, because the longer it goes on, the worse the situation will become in terms of loss of nutrients, and particularly sodium and potassium. And in the case of little joeys, they're short of glucose because they don't have a lot of glycogen stored in their liver, which means they become hypoglycemic, and then they become irritable because they're hypoglycemic and they won't drink, and then they die because they're too hypoglycemic. So depending on the age, they need saline initially as the primary resuscitation fluid. If it's been going for a long time, they need sodium and potassium. And if they're young and small, they need all of that plus glucose, plus water, of course. So some of the fluids that are available, you'd be familiar with these, no doubt. Normal saline is the first port of call. If it's an adult and they're severely dehydrated, then normal saline is fine. However, as I said, if they're young, they need sugar and saline. And there are a number of different ways that you can provide sugar. This particular one has got 1/5% of sodium chloride and 4% of glucose. And there are different levels of glucose. And of course, that changes the amount of sodium because we have to make it isotonic or the same degree of concentration as the normal blood. If they're short of potassium, or we've done a pathology and it shows their potassium is low, then we would certainly start them on Hartmann's because it's got sodium, potassium and some precursor to glucose. Would you give this fluid? No, I wouldn't. No, certainly not. Because what happens if the fluid becomes contaminated, it's a very good culture medium, and so you end up with bacterial and fungal growth. And I only keep that because it's a demonstration of what not to do. That'll kill the patient. All right. There are a few other types of fluids that we use in an emergency, but We won't trouble you with that. They're designed for improving renal function, and they are things like gelafusine, which is used in an emergency, protein replacement fluids, which we sometimes use if the blood protein is very low, because that's important, because other problems will occur, which we'll talk about later. So what next to do with resuscitation? We've given water, we've given electrolytes, we've given some glucose. The next thing to do is to concentrate on the bowel. The first port of call is rest the bowel. The bowel is in distress, it's trying to cope, but it can't. So we need to give the bowel a rest, the same as you would rest a sore leg. So you cease the formula and give oral or intravenous clear fluid only, and remove all solute, that is the solid matter, we don't give at that stage, because that'll just increase the problem with osmotic diarrhoea, and it'll prolong the diarrhoea. So we're going to use clear fluid, one of the fluids that we've talked about already. Now, one of the danger signs that we talk about is if the bowel sounds are very much increased, in other words, the bowel is racing along and it's in terrible distress and panic, that's not a good place to be, because there are a lot of complications that might occur, which I'll show you shortly, things like telescoping, interception of the bowel, which can be fatal if it's not operated on within a few hours. So one thing we need to do is slow the bowel. If we rest the bowel, that'll reduce the stimulus, but we need sometimes to slow the bowel with those drugs called anticholinergic, in other words, buscopan, which is, it can be given by itself, or it can be given in combination with other material, such as these anti-diarrhea fluids, which like Ensal and so on, which contain buscopan and other things. So it's a matter of being a bit selective as to what we give, but buscopan can be essential. We try not to overdo it, because if you give too much, there are other complications, like everything in life. Doesn't matter what you do, there's a complication. So we need to be careful with that. If we slow the bowel too much, of course, it'll stop, and then you've got constipation, and then you've got to start it again. So it's a matter of taking it carefully and slowing the bowel gradually. So there are, doses of all these things to give, so be careful. The next port of call is to treat the actual diarrhoea, to see if we can not only slow the bowel and rest it, but to actually improve the situation with the diarrhoea. And there are a lot of medications that you're familiar with, some of them no doubt, and I've listed them here. Bentonite clay is good. It's not absorbed, it's not toxic. What it does is it just coats the bowel and it absorbs some of the water, and it gives the bowel a bit more of a rest. And bentonite clay is available to anybody from a health food store, or you can buy it in great big tums if you've got an epidemic. A lot of the anti-diarrhea mixtures like Ensal and Scarban contain other things which are components of tree material and plants like kaolin powder or pectin, and they are actually designed to do the same thing. They form a thickening in the bowel, and they give the bowel a chance to just slow down, and they absorb some of the fluid, so it's not so irritating. One really good thing is activated charcoal, and that comes as a very fine powder, or it comes as a liquid. And if you give activated charcoal, particularly if you've got one of the nasty complications of all of this, which is a particular bacterial infection like Clostridium, this will absorb some of the toxin. And if you absorb the toxin, that also reduces the stimulus on the bowel. So activated charcoal is a good thing to do. The only warning, I suppose, is, and we use this in human primates as well in this situation, but if they've got severe diarrhoea, the nurses hate it, because what happens is the next time they have explosive diarrhoea, there is a problem. So you don't stand at this part, you stand over there. But nevertheless, it's a very good thing to give. Now, the other thing is, particularly in macropods, but in all species, having diarrhoea, and if it's going on and on, or even if it's acute, they get very stressed by this. And we're particularly conscious of stress, and the fact that if they've got ongoing stress, that will increase the diarrhoea. So we like to treat the stress as well as specifically treating the diarrhoea. And the drug of choice for me is diazepam. And we use that fairly routinely because it means that the patient is not in a state of terrible panic because it's painful. It's not a painkiller, but it relieves the stress and the anxiety associated with having abdominal pain and associated with having diarrhoea and not being able to clean yourself and being in an abnormal environment. So diazepam is, in my humble opinion, a very good thing to do to relieve the stress. It's called anxiolytic. We're not trying to sedate the patient. We don't want to. We're giving a small dose, which is the anti-anxiety dose. Other things like some people use Carafate, which is a drug that's used as a stomach sedative. It coats the stomach and relieves the acid content and therefore reduces the stimulation of the bowel. And we keep them in a stress-free environment as much as possible. So they should be warm. They should be not in the same room as barking dogs or fractious children or whatever. In a nice, calm, warm, stress-free environment. And of course, they need tender, loving care. We can give as clear fluid, we can give glucose or one of the fluids that are available like vitrate and so on. All of those can be used, but as long as they don't have a lot of solid matter, that is solute, then they're quite appropriate. Treat the diarrhoea, we've mentioned, a good, nice, warm, healthy, stress-free environment we've talked about, and that's a useful thing to do. We've seen that fellow, we'll move on. Now, supporting bowel recovery means that after we've treated all these things chemically and slowed the bowel and coated the bowel and soaked up the toxins and all that sort of thing, then of course, the bowel having been damaged, it's like damaging the skin. It takes time to recover. And particularly when we know from studies in all species that if you've got a severe episode of diarrhoea, gastroenteritis, the bowel will be damaged and there will be microscopic ulcers in the bowel and microscopic bleeding, and we need to do something about repairing that. And the other thing I mentioned right at the outset is that the basic problem with the bowel in this situation is that the ecology of the bowel is disturbed. So we need to try to reconstitute that. So probiotics are useful. And a number of people have different ideas about what's a good and what's not. Different species probably require different probiotics, but we know that Protexin's available. We know that yogurt is available. We know that Yakult is a good form of reconstituting the bowel. And I just make a plug here about, and I'm not talking about PAP, I'm talking about giving fecal fluid orally. I know that it's done. There are a number of issues that I have with that, and including things like, and they're mentioned in the notes, the acid in the bowel will destroy some of the organisms that you're giving orally. The acid in the bowel will kill some pathological organisms, which then release their toxins and damage the stomach wall, and they get absorbed through into the system. And so that can be a bit of a problem with gastritis and irritation that's carried further into the small intestine. What we do is we do a fecal transplant. And this is now becoming, we've been doing this a long time, and it's now become a bit of a rage in human primates in that the gastroenterologists have discovered that veterinary surgeons know quite a bit about this. And so they're taking it on, and good for them because it is a very good treatment. So what we do is we give a colonoscopy, the patient's sedated probably. We do a colonoscopy and we deposit a clean fecal pellet up into the upper reaches of the bowel where it can do its job. It's important doing this that we check the feces beforehand. We don't want to introduce pathological organisms. We don't want to introduce parasites, fungal infection, and so on. So we're very particular about checking the fecal sample beforehand, and then we make it up and we give it up in the upper reaches of the colon, and there it stays and it does its work. And this is a very effective treatment, which particularly when you've got diarrhoea that's been going on for a long time, and by that I mean weeks, often within a day or two, the bowel is slowed and it's discovered its proper self and it's calming down and everything gets better, which means that it's life-saving. Because if the diarrhoea goes on, it certainly will be fatal. There are other drugs that are used, like what are called proton pump inhibitors, which actually reduce the amount of acid in the stomach. And so they sometimes use, but they have their potential complications as well. Here's a picture of a fecal transplant. The patient is sedated, and this tube is passed right up to the upper reaches of the bowel, and the fecal material is deposited up there. So that's what it looks like. It's invasive, but not too bad. It's not particularly unpleasant for the patient because they're partly asleep or sedated, or occasionally we have to give them a general anaesthetic to do it. But it's much better than dying of gastroenteritis. Digestive enzymes like Enzaplex or pancreatin or Creon is the latest one, because some of the others have been taken off the market. Creon is one that's used in human primates, and they are a mixture of pancreatic enzymes which help the patient digest whatever's in the stomach and in the duodenum. So we give that orally, and that helps to make sure that the material that's given to try to resuscitate the patient isn't just passed out. It helps to digest it, and therefore it can be absorbed and it's less irritating for the bowel. Now, dietary supplements, sure, they can be used, and if they contain electrolytes, that's even better. And we mentioned that little joeys need sugar. Things like Nutrigel and Energel provide not only some sugar, but they provide really important things like thiamine or B complex, which is usually deficient because it doesn't get absorbed, and the patient is now suffering from a thiamine deficiency, which can cause cardiac failure. It's all getting very complicated, but it is complicated. And if we deal with all of the known problems, then we get a much better recovery and turnaround. We need to, having made a diagnosis of the problem, we need to give specific treatment sometimes for whatever is the underlying cause. And that can be all sorts of things like worms, for example, and we'll give specific anthelmintics. These are some that have been around a while: ivermectin for strongyloides, Baycox for coccidia, and Panacur for many of the other worms, except tapeworm. We've added B complex in here. This is some fluid to be given either subcutaneously or intravenously. We add thiamine. We always add thiamine because we know they'll be deficient. And so adding thiamine to the mixture is of great benefit. Sometimes we need antifungal agents. Sometimes we need specific antibacterial agents, because in the diagnosis we've made a diagnosis of maybe a clostridial bacterial infection, which is enterocolitis or enterotoxemia developing. And if we don't treat that, they'll still get enterotoxemia. So sometimes we have to give antibiotic treatment orally, which means that we're sort of going against the idea that you shouldn't give antibiotics when you've got diarrhoea. But if we don't do it, then the clostridia can be very nasty. But we're very specific about which antibiotic we give. So, for example, if there is a clostridial infection causing an incipient enterotoxemia, which can be fatal, then we restrict our antibiotics to straight penicillin, which won't destroy all the other bacteria in the bowel. And all the other beneficial bacteria remain, but we calm down the clostridia and therefore take away that nasty part of the whole mixture. Anthelmintics I talked about. Right. Now, outcomes. What happens? Well, what we need to do is to turn this around. This poor little soul, look at the sad look on that face. When they get to this stage, they're heading in very rapidly in the wrong direction. And without some fluid therapy, urgent fluid therapy, and a few other things, this little bloke will die. So what we need to do is turn it around and end up with a much better outcome, like this, or this, or this. Going back a step, we have sometimes this little fella here is looking pretty sad as well, and he's going to need a lot of treatment with regard to fluid therapy. He's already getting a seborrheic dermatitis here, so we may need to do something about that. We look at these feces and check that regularly to make sure that it's actually improving. So we might do fecal examination every day. One of the big deals in all of this is pain, and pain is stressful, and it keeps the diarrhoea going because the bowel is under stress and it's hyperactive. So we need to calm the pain because that will mitigate against a good recovery. There are lots of drugs that we can use to calm the pain, things like tramadol, paracetamol with codeine. Codeine actually helps to slow the bowel a little bit. There are some drugs that we don't use, and I'll talk about those later. Hyperacidity, we've talked about that. Moving on. With this excess activity in the bowel, and you've probably all seen this situation, which is the bowel starting to prolapse because it's too active and it's moving along too quickly, and therefore it's lost control. And what will happen at the cloaca is a little part of the bowel will start to protrude as a prolapse. Now this is all right at this stage, we can manage this, but if it goes on any further, we end up with this very nasty situation where this bowel is dying and the patient's going to die if we don't do an operation to resect that part of the bowel. And this can happen internally as well. But we want to avoid that by treating a prolapse at this early stage, which can be done as long as it's done carefully. It's a matter of lubrication and sedating the patient. Diazepam, once again, is useful. And then lubricate the prolapse, and we gently push it back in. I don't expect you rush out and do that, but sometimes we have to guide carers over the phone because this is urgent. And we will guide you as to how to do that to get this little prolapse back in. And it's not necessarily easy. Sometimes it takes a while, and occasionally what happens is on a gloved finger, obviously, and a suitable size finger, according to the size of the patient, then with a lubricated gloved finger, we gently ease the prolapse in, back inside the pelvis. And of course, if you then stop, it'll come out again. So sometimes you need to sit there with your finger up the Joey's backside for half an hour. It's not such a big deal. They don't sort of mind, I guess, but it's the only way it's going to stay there because it needs time to settle. And the spasm needs time to settle. And that gives you a clue that the amount of spasm in the bowel is excessive. So we need to concentrate, then go back a few steps and do something more about relieving the spasm, which will help with the diarrhoea, and it will prevent this, and even worse, this, because that's a disaster. And internally, what might happen is that you get this problem where you can see, here's the bowel, here's some more of the bowel, and you can see this part of the bowel has worked its way into this part of the bowel, and it's all the way down to there. This is called an intussusception. Everyone heard of an intussusception? Yes. It's potentially a big problem, and unless we operate on this, Joey, within a few hours, the bowel will die. And then you've got a more major problem. So this is what an intussusception looks like internally as opposed to a prolapse externally. But it's the same thing happening. So we need to try to avoid this by keeping the activity in the bowel under control. And if this does occur, then that's a matter of a diagnosis that we have to make with clinical diagnosis and ultrasound, and then do an urgent laparotomy to relieve this. Once it's relieved, it's fine, but we need to get to it early. And if it stays, it's like having a tourniquet on the bowel. If it's left too long, the bowel will die, and then you've got a major problem, with not only an intussusception, but a dead bowel. And this will be, if we're not really careful, this would be a fatal outcome. So the earlier the better, in other words. There's a whole list of things here. I don't know that we can go through them all, but the other thing that happens is the pancreas can be damaged by this excessive activity, which gets out of control, and instead of peristalsis moving in the right direction from top to bottom, it starts to reverse, and that's why we get the intussusception. So things are chaotic in there, and in that situation, what also happens is that fluid gets pushed up into the pancreas. And then what happens is the pancreas starts to digest itself. And so you get acute pancreatitis, which can also be fatal. So there's a lot of problems with this, but I don't expect that you are going to make this sort of diagnosis. But what you do need to be aware of is that there are lots of complications of a simple gastroenteritis. And I'm just trying to alert you to that, not trying to give you the whole of veterinary medicine in half an hour. Well, we've got till midnight, haven't we? Not quite. Okay. All right, we'll move on quickly. The bowel, when it's under stress, it tends to lose its integrity and its antibody protection, and so toxins get moved into the body, and you end up with the fatal enterotoxemia, and the heart fails and so on. You get splitting in the anus, which is called fissure in ano. You get soiling around the cloaca, and they don't like that. That's terribly stressful. They don't groom properly, and that's also stressful. They get muscle weakness from loss of potassium. They become malnourished, and in this case, they, over a period of time, and it takes not too long, but you end up with a loss of calcium absorption, and you end up with pathological fractures. And so this Joey that had diarrhea 3 weeks ago has now got 2 broken legs, or however many. So there's 2, one there and one there. And this is an end result of an ongoing relentless diarrhea from loss of calcium. The other thing that I'll mention here is something that came up earlier this afternoon, and that is the failing system, and they go into a state of general body failure. What I think is that the adrenal gland, which is initially stimulated to produce cortisol and adrenaline, when it's overstimulated for too long, which is what happens to any wildlife in long-term captivity if they're not kept in a suitable environment, and it happens to people who live that sort of lifestyle, is that the adrenal gland becomes exhausted. And so it doesn't produce enough cortisol, and so the body just fails and dies. And that's called an Addisonian crisis. We know a lot about that, and we treat it, and we get them through it. But it's a matter of recognition, and that will happen over a long, extended period of stress from anything, whether it be diarrhea or any other stress. So I've mentioned that in your notes as an Addisonian crisis. They become hypoglycemic and then go into a coma. They aspirate if they're forced to drink when they shouldn't be. They lose a lot of protein and get edema and heart failure from that. They lose B vitamins and they get heart failure from that, and so it goes on. Failed immunity, they get all sorts of other infections. They can get myopathy from the stress of it all, and finally they die. So, but we can avoid most of that by dealing with this problem early. General things to think about going through this. An early diagnosis is critical so that it can actually be treated. And we need to not only treat the general body failure and dehydration, but to treat the underlying cause, whatever that might be. Diarrhea is potentially fatal, and it should be treated as a serious disease, particularly in the young. Dehydration is the primary killer, and so fluid therapy is the most important thing. If we know there's a problem going on, then prophylaxis is used to avoid that. For example, if there's recurrent coccidiosis in a facility, then we need to treat as a prophylaxis so that they don't get coccidiosis. And there are good drugs for all of this. We can treat or prevent enterotoxemia by vaccinating them with a 5-in-1 vaccine. and that's fairly well understood. Antibiotics are sometimes necessary. If we manage their diet properly, they won't get any dietary indiscretion. Strongyloides is a particularly important worm. Hitherto, it's been regarded as, oh, well, we all have worms, but no, Strongyloides is a particularly problematic worm, unlike some of the other parasites. And we need to, I think, with little ones in captivity or either older patients, we need to prevent Strongyloides because it can have far-reaching effect not only on the bowel, but in the joints and the heart and the lung and so on. A very common problem is a fungal infection or yeast infection or thrush, candidiasis, and that's fairly simply treated. In the first instance, nystatin is effective, but if it's not, then we can progress to fluconazole. But nystatin is terribly safe, whereas fluconazole has potential complications. Under other drugs to inhibit the acid content in the stomach, I've mentioned already. Antiemetics sometimes, they rarely vomit, but in some other species other than marsupials, they do vomit and sometimes need drugs to control that. Quarantine is important because some of these infections are communicable to any others in the group. So it's important to quarantine them. And a critical measure, they don't like being dirty, they don't like all of this going on. So perfect nursing is really important all the time. It helps with their mental health and it helps with their general body health because it keeps them clean, it reduces spread of infection, and they feel much better. So really good quality nursing is critical. Dehydration, 10% is life-threatening, and that's a critical thing to deal with. My advice is to seek veterinary help early on, not leave it until the patient is dying. I think that's really important, and we do see that quite a lot in that the patient presents after 3 weeks of diarrhoea. They don't move, they look like some of these poor little joeys that we put up there before, and that's really pushing it to try to bring them back from the dead. Surgery is life-saving if need be. Fecal transplant is life-saving. As with the skin, recovery takes time, and a damaged bowel can take 2 weeks to recover, which means we need to support the bowel for 2 weeks, and we need to support the nutrition and the mental health of the patient for that length of time until the bowel does recover. I mentioned high-quality nursing. Now, corticosteroids, going back one step to, we talked about an Addisonian crisis. That's because of failure of the adrenal gland producing cortisol. So we use corticosteroids quite a lot because they improve the blood pressure, they stabilise the circulation, they improve the mental health, and a whole lot of other things. They improve the blood sugar in the little fellas, and they deal with this Addisonian failure. So sometimes we might keep corticosteroids going for a week or 10 days or more, but at a particular dose. So it's not something that we just rush in and give a great big dose. It has to be sorted in a way that it's going to be therapeutic and not forever. People will say, well, it destroys their immunity. Well, it actually doesn't, depending on how it's managed. And I've had patients, human primates, that have been on corticosteroids for 30 years, and it hasn't destroyed their immunity because the amount that we give is managed. And that's what we do, and it can be given orally. So that's a really important concept. Don't be frightened of corticosteroids. They get a lot of flack, but they're very useful and life-saving as long as they're managed properly. Another drug that we use occasionally, which I guess has become a bit of a no-no in some quarters, but anabolic steroids used to be very common, but they're used a lot less now because of the input of bodybuilders. These are the drugs that improve muscle mass and so on. Because of bodybuilders and weightlifters and now cyclists and swimmers and everybody else is taking anabolic steroids, which are illegal now, didn't used to be, but they are now illegal. So they're restricted, but they're life-saving in our opinion. So we use anabolic steroids, not all the time, but they're available to act as they help to turn around the metabolism so that instead of everything being destroyed, everything turns around and they start to grow more muscle and their mental health improves and their appetite improves and so on. Some medications can exacerbate the problem. We'll just move on. Here's what we're aiming for. This is a fairly serious situation with diarrhoea or bowel infection. Dehydration is critical, and we can use these little paediatric bags if you want to try and collect fluid. Unfortunately, this Joey is totally uncooperative, and the first thing we get is a fecal pellet, which means that now the urine sample is useless to test because it's now contaminated by a fecal pellet. So anyway, we try, we move on. Prophylaxis, avoid this. This is a dead bowel. And that the only way this patient will survive is to have that bowel resected from down here to in there. And that's a fairly major event. Seek veterinary help early, because regardless of the cause of the diarrhoea, which can be not necessarily anything in the bowel, but we see this not infrequently. There's some, I won't say who, out there doing this to our wildlife, which is just unbelievably appalling. This poor bloke is under severe stress. He needs your attention and then my attention as soon as possible, because he's in a situation, not only is he in great pain with this, but his bowel will be reacting to the stress and he'll probably end up with severe diarrhoea and so on. Surgery can be life-saving. Here's a repair of a bowel that's been resected after either a dead bowel or an intussusception. So it can be done, it is done, and the patient do survive. So nothing's off the list. Medications, there are some that we use. I mentioned about corticosteroids, I mentioned about anabolic steroids. Here's another anabolic, which sadly doesn't exist anymore. So some medications, and I mentioned a few of them in your notes, like non-steroidal anti-inflammatories, and the evidence of this now comes from not only veterinary literature, but human literature is discovering or talking about the fact that non-steroidal anti-inflammatories of any kind can be very dangerous in situations of dehydration and stress. They end up causing things like renal failure, excess bleeding, and peptic ulceration, which then leads to a ruptured bowel. So avoid the non-steroidal anti-inflammatories. Absolutely. They're good drugs for what they're designed for, but not for this situation. Antibiotics, we have to be careful. Yes, sir. Ma'am. Well, I'm not trying to pick on any particular one, but non-steroidals are things like aspirin, meloxicam, and a whole list of others. There are many, many of them, and I'm not decrying anyone in particular. They all have their use in a different situation, like with arthritic pain and so on. But when you've got dehydration or severe stress, whether it be for this or after a motor vehicle accident, in my humble opinion, we shouldn't use them because they do cause complications, which we see all the time. So I'm not being critical of them generally, I'm just saying don't use them. 1 minute. Huh? 1 minute. I'll be quick. I'll double the speed. Some antibiotics need to be avoided. We've talked about that already, like broad spectrum antibiotics given inappropriately. If we need to give penicillin for clostridial infection of the bowel, sure, we'll do that, but it's controlled. We don't give broad spectrum antibiotics for maybe they might be useful. And particularly in herbivores, we don't give them orally generally, because they will upset the bowel, and then you start the cycle of an enteric disruption. So after all of that, which is a bit sort of life-threatening for all of us, the things that we need to remember is don't give up. It can get better, even though the patient may not appreciate it. It can get better. And thank you for your attention and your caring. We do appreciate it.